Hello guys, and welcome to a tutorial on cranial nerve number 7, which is going to be the facial nerve. The facial nerve will have both a motor component and a sensory component. The motor component originates from the facial motor nucleus that we find in the tegmentum of your pons, particularly on the ventrolateral part. And the axons from that nucleus, they're actually going to cross dorsomedial and they form a compact bundle that we refer to as the internal genu. The sentinel genu is going to loop over the caudal end of the abducens nucleus, and that's going to be beneath what we call the facial colliculus that we see in the rhomboid fossa when we are looking at the dorsal aspect of the brainstem. And after leaving the genu, the fibers from this internal genu are going to pass between the nucleus of origin, which is the facial motor nucleus, and the spinal trigeminal nucleus, and it's going to emerge then at the pontomedullary junction together with its sensory root, which we call the nervus intermedius. Of note, the two roots are actually going to be different, as I'm going to show on the diagram on the subsequent page. Right. So the facial nerve is going to have four functional components. We're going to have spatial visceral efferent fibers. Then we're also going to have general visceral efferent fibers. Then we have spatial visceral afferent fibers as well as the general somatic afferent fibers. The easiest would be the general somatic afferent fibers, which are simply carrying general sensations from the auricle of the ear, and they terminate in your spinal nucleus of the trigeminal. Then the spatial visceral efferent fibers are simply going to innervate structures that are originating from the second pharyngeal arc, which is going to be the muscles of facial expression. The fibers for these spatial visceral efferent fibers originate in the facial motor nucleus that is located on that ventrolateral part of your tegmentum of the pons. Then we're going to have general visceral efferent fibers, which are going to be simply ganglionic parasympathetic fibers, which arise from the lacrimatory and the superior salivatory nuclei, and they're going to innervate the lacrimal gland, the sublingual, as well as your submandibular gland. Then the spatial visceral afferent fibers, they're going to carry taste sensations from the anterior two-thirds of the tongue, and they terminate in the nucleus of tractus solitarius, and then they ascend via the central tegmental tract to terminate in the ventral posterior nucleus within the thalamus. Then from there they ascend to the test area that is just adjacent to the general sensory area. Right. So this is a schematic that is showing us the facial nerve. So we're going to have the midbrain, the pons, then the medulla. At the pontomedullary junction, you have exit of cranial nerve 6, 7, and 8. But for the purpose of this video, I've shown cranial nerve number 7, where we're going to have the black one being the motor root, then the orange one being your sensory root, the nervus intermedius, which lies between the motor root medially and the vestibulocochlear nerve laterally. So these two, they're originally separate, and together with the vestibulocochlear nerve and your labyrinthine artery, they course within the cerebellopontine angle, and from that cerebellopontine angle they gain access into the internal acoustic meatus, and within the internal acoustic meatus, towards the lateral end, the two roots are actually going to join, and they merge into one facial trunk that are actually synapses within your geniculate ganglion here. Right? And from the internal acoustic meatus, you'd find that this facial nerve will then enter what we call the facial canal. And the facial canal will have three parts. It's going to have a labyrinthine part, it's also going to have a mastoid part as well as a tympanic part. Most importantly, in relation to this geniculate ganglion, will be the labyrinthine part, where there is a sharp curve within that facial canal. And this facial nerve trunk will also have a sharp curve in the region of this geniculate ganglion, where we're then going to have the external genu. Because earlier on we talked about an internal genu within the brainstem. Right? So at the level of your geniculate ganglion, you're going to give off a nerve, which is going to be the greater petrosal nerve. Right? This greater petrosal nerve is going to be carrying preganglionic parasympathetic fibers, and it joins the deep petrosal nerve, which is coming from the sympathetic plexus around your internal carotid artery, and they form a nerve that we call the nerve of the pterygoid canal. This nerve of the pterygoid canal will then synapse at your pterygopalatine ganglion and will send fibers to the lacrimal gland, which will be secretomotor for tear production. Meaning, lesions of the facial nerve proximal or distal to this geniculate ganglion can actually be distinguished using lacrimation. Right? Then, whilst in the facial canal, you give off a nerve to the stapedius. Remember, the stapedius is one of the small muscles of the ear, and it's actually the smallest muscle in the body. And the stapedius, together with this fellow, which is your tensor tympani, which is innervated by the mandibular division of the trigeminal nerve, they help dampen the sounds, meaning problems with the facial nerve will also present with hyperacusis, which is one of the presenting features of your Ramsay-Hunt syndrome, where you affect the geniculate ganglion. Then you also have the chorda tympani. The chorda tympani, more importantly, it's going to carry general visceral efferent and special visceral afferent fibers. The special visceral afferent fibers are going to be for the anterior two-thirds of the tongue for taste. Then the general visceral efferent fibers are going to be secretomotor to both the submandibular gland and the sublingual gland. Right? But of note, this chorda tympani nerve will each hike via the lingual nerve, which will in turn be carrying sensations to the anterior two-thirds of the tongue, and they will travel together as one nerve. Then your facial nerve will then exit the cranium via the stylomastoid foramen to emerge onto the face. And just after exiting, it gives off a posterior auricular nerve, which is going to innervate your occipital belly of the occipital frontalis. And it also gives you a nerve that innervates both the stylohyoid muscle as well as the posterior belly of the digastric muscle. Remember, the anterior belly will be innervated by your mandibular division of your trigeminal nerve. Then your facial nerve will then enter the substance of the parotid gland, where it then terminates into its 5 terminal branches, easily remembered using the mnemonic to Zanzibar by motor car. So it's going to be the temporal branch, the zygomatic branch, the buccal branch, the marginal branch, as well as the cervical branch. The temporal branch will give you branches for the frontalis, then it also gives you branches for the upper part of the orbicularis oculi. It also gives you branches for the corrugator supercilii. Then your zygomatic branch will give you branches to the lower part of your orbicularis oculi. And more importantly, this cervical branch will innervate the platysma muscle. Though not really on the face, it's in the superficial fascia of the neck and also helps with facial expressions. Then the marginal branch will innervate your risorius, the mentalis, as well as the depressors of the lip. Right. Then clinically, lesions of the facial nerve, we can have a supranuclear lesion, and the supranuclear lesion will spare the upper part of the face, and only the lower half of the face on the contralateral side will be affected, for the reason that you have contralateral or bilateral rather corticobulbar innervation, and if you're going to have a supranuclear lesion, the other side will still innervate the contralateral side and the same side, so only the lower half will be affected because there is bilateral corticobulbar innervation for the upper face. Right? And there's what we call the crocodile tear syndrome, where you're going to have a lesion just proximal to the geniculate ganglion, where when there is now nerve regeneration and nerve healing, the fibers for the greater petrosal that is supposed to grow to the lacrimal gland would then have an association with the fibers that are going towards your oral cavity. So you end up with fake tears in response to, say, taste or anything. So it can actually be these fibers growing towards the glenopetrosal nerve instead of growing back into your chorda tympani nerve. Right? There's what we call Ramsay-Hunt syndrome, which is basically involvement of this geniculate ganglion, and it's going to be affected by herpes zoster, and it presents with things like hyperacusis because you affect the stapedius muscle. Also presents with loss of lacrimation because you affect the greater petrosal nerve, loss of taste because you affect your chorda tympani nerve, and you also have generally a Bell's palsy. Bell's palsy is a lower motor neuron lesion of your facial nerve and presents with facial asymmetry. There is loss of the horizontal wrinkles on your forehead. There is widening of the palpebral fissure because there is weakening of the orbicularis oculi, and that same weakening results in epiphora, which is now tears flowing on the face. Then you have dribbling of saliva from the angles of the mouth, as well as loss of resistance when one presses the cheek, because normally when you blow out air, the backscatter muscle should be having a normal tone, and if you try to uh, put it in inward, it will have resistance. But in Bell's palsy, there is loss of that resistance. So that's just about it. Thank you.